Hello, this is Professor Jones. I am here to talk to you about aneurysms and dissections. Aneurysms and dissections. The objectives for this lecture are to identify risk factors for the development of aneurysms and dissections, to talk about collaborative care, how these disorders are treated, to talk about nursing interventions necessary in the care of a patient with one of these disorders and having treatment for it, and to talk about emergent interventions in the care of a patient with a ruptured aneurysm or dissection. So to start with, we're going to talk about cerebral aneurysm. And in general, an aneurysm is an outpouching in an artery. This can be caused by many different factors. Some of them are hereditary. Some risk factors include hypertension, smoking, other genetic causes. Typically, aneurysms are not symptomatic until they rupture, so this makes them a rather dangerous pathology. Aneurysm has been referred to as a silent killer because patients really don't know that they have an aneurysm until the aneurysm ruptures. And when a cerebral aneurysm ruptures, it is usually a catastrophic event, typically heralded by the worst headache of my life, and can be followed quickly by loss of consciousness. This headache is very particular. I've had patients tell me like no headache they've ever had before. It's usually referred to as the worst headache of my life, sometimes as a thunderclap headache. Patients talk about, like thunder going off inside their head, and it's a sudden onset. Ruptured cerebral aneurysms cause bleeding into the subarachnoid space in the brain, which is a specific type of hemorrhagic stroke with high mortality. And I separated out this lecture on cerebral aneurysms with aortic aneurysms just because I want you to understand these are vascular disorders that have high mortality and high morbidity. So what is an aneurysmal subarachnoid hemorrhage? That's a lot of big words strung together. Basically, that's what happens when a cerebral aneurysm ruptures inside the brain. The majority of these aneurysms occur in the circle of Willis, where all the large vessels are. The incidence of having an aneurysm does increase with age. It's a higher occurrence in women. It is often referred to as a silent killer. And loss of consciousness may or may not occur with the initial rupture, but it does have a very high mortality rate, and even patients that survive often suffer significant complications and neurologic deficits. Types of cerebral aneurysm are described by their size, their shape, actually. So these are the three different kinds here. The first on the left is called saccular. It's kind of just a round berry shape. And then you have fusiform aneurysms, which are kind of, like oval in shape. And then this one here is actually a dissection. So you can see the original vessel inside the aneurysm, and the lining has kind of split apart around the blood vessel and created an aneurysm around it. And this visual is important because a dissection is a complication that we're going to talk about later in this lecture. So what are the risk factors for this occurring? Smoking. Smoking is always bad. People that quit smoking are doing the number one thing they can to improve their health. If your patients smoke, please, please, please encourage them to quit. Patients also that are over age 40 and have high blood pressure, those patients are at a higher risk for cerebral aneurysm. There can be some congenital risk factors resulting from an inborn abnormality in blood vessels in the arteries, or an AVM, which is an initial that stands for arteriovenous malformation. These are inborn kind of malformed blood vessels that are at higher risk of having an aneurysm. A family history of brain aneurysms also puts someone at risk, and if someone has had a first-degree relative have a cerebral aneurysm, it is definitely recommended that they tell their PCP and get a screening CTA to rule out any aneurysms, because remember, these aneurysms are asymptomatic until they rupture. Drug use, particularly cocaine, is very bad for your blood vessels, and patients who use cocaine not only have, are causing damage to their blood vessels, but they're also raising their blood pressure, which is another risk factor for aneurysms. So gender is another risk factor. Women compared with men have an increased incidence of aneurysms at a ratio of 3 to 2. So this is my case study. So you're watching your husband's for fun. Yeah, your husband. He's a soccer player, and he's playing for fun, and he leaves the game and is kneeling on the ground. And when you try to assess what's going on, he says, "I've got a terrible headache. It just started." And you know that sometimes he gets headaches when he's stressed, and you ask him if he is feeling stressed, and he almost screams back at you, "No, this is the worst headache of my life. What should you do?" So knowing what you know about subarachnoid hemorrhage, you know that rapid onset worst headache of life may be the patient having a ruptured aneurysm. And you know that this is a disorder with high mortality, high morbidity. About 50% of patients who have a subarachnoid hemorrhage die, 35% right at onset, and 15% from subsequent or rebleeding. Thank goodness the incidence is very low, 6 to 25 patients per 100,000, and the risk is higher in women than men. Patient that says, "I'm having a terrible headache, the worst headache of my life that just comes on," is the most common presentation, and it can happen during strenuous activity, can happen during weightlifting, can happen during sex. Patients that have strenuous exercise can rupture aneurysms because of that. They also can be inherited, so it's important that first-degree relatives ask for screening tests, and we'll talk about testing a little bit later. So when an aneurysm ruptures in the head, it causes bleeding into the subarachnoid space. Hence, it is called a subarachnoid hemorrhage. Treatment for subarachnoid hemorrhage involves either surgical clipping of the aneurysm or endovascular coiling of the aneurysm, occluding the aneurysm and removing it from circulation, effectively taking the risk away and stopping the bleeding. Patients can have a complication known as vasospasm, and to prevent this, nimodipine is given to these patients. It is a calcium channel blocker. It dilates the vessels, but it also drops the blood pressure and heart rate. Patients that have subarachnoid hemorrhage are kept euvolemic, so they are given fluid replacement as necessary. So you recognize that the sudden onset of the worst headache of my life, aka a thunderclap headache, could be from a ruptured cerebral aneurysm, and you call 911. The EMTs arrive to the soccer field as your husband becomes sleepier and confused. They rush him to the nearest stroke center, where he is immediately sent for a CT scan of the head, right? Because this is still stroke. You still want him treated as if he's having a stroke, because he is. And he goes for a plain head CT, which shows up blood in the subarachnoid space. Because it is a ruptured aneurysm, which is a blood vessel disorder, the next study that is going to be done will be a blood vessel study, a CTA. And this type of stroke can be treated in several ways. We're going to talk about them next. So the plain head CT without contrast is going to show blood in the subarachnoid space. Blood shows up bright white, and it shows up as a distinctive crab or chicken-like pattern. It's been fondly called the chicken of death for some patients. And when you Google subarachnoid hemorrhage CT, you'll see many different chicken and crab-like patterns. The next study that's typically done if a vessel rupture is suspected is a CT angio, which is a study that's done with contrast injected into the IV, and it shows up the cerebral blood vessels and hopefully will pinpoint the location of the cerebral aneurysm. In this way, the patient can be set up for treatment. Angiography, which is an invasive study where doctors go through the groins with small catheters and actually examine the blood vessels, that can identify the source of subarachnoid hemorrhage, and it also can be used for treating the subarachnoid hemorrhage with catheter-directed therapies like coiling. So the same interventional radiology procedures that can be done for stroke, like removing a blood clot from the cerebral vasculature, you can use those same catheter-directed therapies to treat subarachnoid hemorrhage. So if the aneurysm is in an amenable place for surgery, so say for example I have an aneurysm that is in my anterior communicating artery and it's close to the surface and the surgeon feels like it would be an easy place to get to, they will do surgery, brain surgery, through my skull and put a small metal clip like this at the base of the aneurysm, effectively taking it out of the circulation. That's always the goal of treatment with a cerebral aneurysm. You want to remove that from circulation because you're worried that your patient could re-bleed if that aneurysm, became open again. If the aneurysm is not amenable to clipping, or if the surgeon feels like it's easier for the aneurysm to be treated using endovascular techniques, the radiologist can go through the patient's groins into the arteries and place tiny flexible coils into the sac of the aneurysm to occlude it and also take it out of circulation. Both procedures can be done for a ruptured or an unruptured aneurysm. Obviously, a ruptured aneurysm is an emergent situation, so those patients are going to be considered unstable until the aneurysm is secure. We talked a little bit about nimodipine and about vasospasm in a previous slide. One thing that you should know is that vasospasm is a consequence of blood products in that subarachnoid space in the brain. It's very irritating. It can cause further strokes because the blood irritates those vessels and they clamp down, they constrict. So patients with subarachnoid hemorrhage are at risk for vasospasm, and it's treated with nimodipine. Patients also receive Provocol because a couple studies have shown patients do better if they're started on a statin, and their fluid status is watched carefully and they are given IV fluids to keep them euvolemic or even. So if your patient voids 500 mLs, the nurse gives a 500 ml bolus to keep that patient even. The blood pressure of these patients is also managed really closely. So a CT angio is done for your husband and they locate a ruptured aneurysm and it's amenable to coiling. So he goes to the angiography suite where a specially trained neurological interventionalist goes in through the groin with a catheter and puts his little catheters and wires all the way up to the patient's head where these tiny flexible coils are deployed, and they are packed nice and tight into that aneurysm until it's effectively occluded, and it will heal over at that area where the aneurysm starts, and that will prevent it from bleeding further. So these patients are usually taken care of in a neuro ICU. They are given hyperdynamic therapy, which means their MAP, their mean arterial pressure, is set at a goal, and usually it's the nurse's responsibility to monitor closely and make sure the patient is meeting that goal. They're also given lots of fluid replacement to keep them even, and they want patients to have good cerebral perfusion. They don't want any vasospasm. They don't want any complications from this subarachnoid hemorrhage. and patients get nimodipine to prevent vasospasm. So the care for these patients is similar to the care of any stroke patient, with special attention paid to neurologic changes. The nurse does frequent neurologic checks. It's every hour, and they're in the ICU, and notifies the provider with any changes which may indicate vasospasm. The nurse is responsible for keeping track of that fluid balance, and usually fluid is given to make sure the patient stays even. The patient may have severe headaches that need to be managed with medication. Opiates are very common for these patients because they do have terrible headaches from the irritation of the blood in their head, and their blood pressure has to be managed very closely. Sometimes their blood pressure is artificially increased to keep those vessels open. So moving on, another vascular emergency, vascular disorder, is an aortic aneurysm. So the aorta is the largest artery in the body, and an aneurysm is a permanent outpouching or dilatation of the vessel wall. Aortic aneurysms are more commonly seen in men than in women, and it increases in incidence with age, hypertension, coronary artery disease, a family history, hyperlipidemia, history of stroke, tobacco use, and obesity. So there are a lot of different risk factors that can lend a person to having an aortic aneurysm. So moving on, an aortic aneurysm is divided by location. A thoracic aortic aneurysm is found above the level of the heart, and an abdominal aortic aneurysm is below the level of the heart. They can be saccular, like in the cerebral aneurysms we just saw, the round berry shape, or they can be fusiform, like this picture here. This aneurysm of the thoracic aorta is a fusiform one. It's kind of like a vase or an urn shape around the vessel. Most are asymptomatic, and they can be found during routine examinations, or they can be found on scans incidentally. And AAAs in patients that are on the thinner side can sometimes be palpable. Risk factors for aortic aneurysm include tobacco use, age, people older than age 65, men and white men have a higher risk of abdominal aortic aneurysms. Patients with a family history of abdominal aortic aneurysms are at higher risk. Atherosclerosis, the buildup of fat in your arteries, can damage the lining of a blood vessel, putting you at risk for an aneurysm. And high blood pressure as well increases your risk of developing a AAA. So this is our case study for a AAA. She's a cute 81-year-old female patient. She is a Jehovah's Witness and does not accept blood transfusion. She came into the hospital with an expanding aortic aneurysm that had enlarged from 5 to 7 centimeters. Now normally your aorta is 2 centimeters in diameter. So 2 to 3. She's kind of a tiny woman, so I would be surprised if it was larger than 2 normally. But her aorta has an aneurysm that is 7 centimeters in diameter. So if you imagine that inside your belly, that's a pretty good size aneurysm. And because she's elderly, and because she's a Jehovah's Witness and does not accept blood transfusions, an minimally invasive endovascular repair, or EVAR, was chosen as the ideal treatment method, since the expected blood loss is decreased dramatically compared to traditional open aortic surgery. And oftentimes with these vascular disorders, having an endovascular repair, like even a cerebral aneurysm, a clipping or a coiling are a big difference in how the patient is treated. So a clipping means the patient actually has to go for a craniotomy and have their brain surgery, whereas a coiling means that the patient is just going to have an access in the groin, and they're going to have the repair done completely within the vascular vasculature. So when you say endovascular, it means inside the vessel. So that's what this lady is going to have here for her abdominal aneurysm. Diagnostic studies that are done for AAA include a CT of the chest and abdomen, a TEE, which is an echocardiogram that is done kind of through the esophagus. It's short for transesophageal echocardiogram. A lot of times these echoes are better at looking at kind of the back of the heart. They go down the throat with a small camera and take a look at the back of the heart, and they can see aneurysms that way. They can use ultrasound of the abdomen, and patients can also have an MRI of the chest or abdomen to look at aneurysms. The Preventive Services Task Force in the United States recommends that men ages 65 to 75 who have ever smoked should have a one-time screening for abdominal aortic aneurysms using abdominal ultrasound. And men ages 60 and older with a family history of AAA should consider regular screening for the condition. And why do you think it's so important to screen for aneurysms? Well, couple reasons. They are asymptomatic until rupture, typically asymptomatic, and a rupture of a AAA is a catastrophic event with very high mortality, as we're going to talk about soon. So, rupture of an aortic aneurysm is an immediate emergency. This patients often complain of a sudden onset of severe pain in the chest, stomach, back, or neck. The patient is likely to say that something is very, very wrong. Patients may have a big difference between blood pressures in one arm versus the other, and they also report the character of the pain as sharp, tearing, ripping, or moving. This is definitely a medical emergency. The mortality rate for a rupture of the aortic aneurysm is 90% out of hospital. And just to give you an idea, if someone damages their radial artery, right, it's a small artery at the wrist, they have 2 minutes before they expire. Like, you will bleed out from that high pressure blood system in a couple minutes. The aorta is the largest blood vessel in your body. So if that becomes open, you have a very small chance that you're going to get a repair done and survive if you're outside the hospital. It just takes minutes for people to bleed out. So definitely a medical emergency. To do surgical repair for a ruptured AAA, the patient has a large abdominal surgery. So the patient's, all their organs have to be moved. The kidneys have to be clamped. So the patient can have a lot of sequelae of the surgery alone. The actual process is the surgeon takes a graft to the aorta and sutures it proximal and distal to the aneurysm. So say here is the aneurysm in the picture. The surgeon is going to open up that damaged blood vessel, that damaged artery, and sew this pretty little white Dacron graft on. And while all this is happening, your arteries that go to your kidneys are being clamped. So, and your lower extremities pretty much. I mean, there's a lot of, it's important that the surgeon can do this in a time where they don't compromise blood flow to the kidneys and the lower extremities. Minimally invasive endovascular repair is an alternative to open endovascular repair for select patients, including our case study lady, because she's elderly and it's much less blood loss for these patients that have an EVAR. It involves the placement of a sutureless aortic graft into the abdominal aorta inside the aneurysm. So the doctor is going to go in through the femoral artery and bring this graft piece by piece into place. And when they're in place, they are deployed against the vessel wall by balloon inflation. So the blood flows through this graft and prevents further expansion of the aneurysm. And it's all done with catheters, and the graft prevents further expansion of the aneurysm. So the lady in our case study, the 81-year-old lady, had an endovascular repair. The case took 7 hours. Blood loss was minimal, and during the case, because they knew she didn't accept transfusions, they used cell saver technology to return her own blood to her, which she had agreed to before the case. She went to the ICU after the case was completed, where frequent checks of neurologic, renal, and cardiovascular status were done. She was very lucky, and after a few days of physical therapy, she was able to walk on her own and was discharged from the hospital after an 8-day stay. If a patient is eligible for endovascular repair of their aneurysm, or in some cases, if a person is too sick to tolerate an open surgical repair, they may undergo endovascular aneurysm repair. Over time, the open repair and the endovascular repair have similar mortality rates. One of the complications of a AAA repair, either open or endovascular, is intra-abdominal hypertension and abdominal compartment syndrome. So one of the most important things that nurses monitor for postoperatively is a patient's urine output. And sometimes if the concern is that the patient will have abdominal hypertension, the nurse might be asked to do a bladder pressure, where you hook a transducer up to the Foley catheter to kind of try and measure the pressure inside the patient's abdomen. These patients postoperatively, especially the open repairs, can be very, very sick, and they can have any kind of postoperative complications ranging from mental status changes, kidney failure, and a lot of times their blood pressure is very labile as well. These patients do go to the ICU postoperatively. So postoperative management of these patients, the nurse has to pay attention to many different things. They usually are in an ICU for the first day or two postoperatively. The nurse is going to manage these patients by watching their blood pressure, paying attention to their peripheral pulses, and their renal and neurologic status. Patient urine output is one of the best ways to make sure their kidneys are working well. And you're going to make sure that they have good neurologic status, that they're able to follow commands for you. You're going to manage their fluid and electrolytes, and you want to make sure that they have good pain control. The patients with open repairs, you're going to make sure that you watch for intra-abdominal compartment syndrome. Make sure you're watching their urine output. Watch their blood pressure. They tend to be pretty sick patients and have a high risk of complications after surgery. So once again, the nursing goals for these postoperative AAA patients: make sure they have good perfusion distal to the graft. So you're going to make sure you mark those pulses on the feet, and you're checking them as often as ordered. Make sure their urine output is adequate. No signs of infection, so any temperature after surgery, any elevated white blood cell count, you're worried about infection in these patients. Make sure that they are following commands and awake after surgery, and that they don't have any neurologic insult from their surgery. And this table on page 813 is something you should all have a look at and review that information for these patients after having a repair of an aneurysm. Once the patient is out of the ICU, you're going to tell them to gradually increase their activities. They may have many complications days after surgery. Make sure they don't do any heavy lifting. They can have trouble with their bowels. They can have poor appetite. They can have sexual dysfunction because it's a vascular repair. So sometimes the blood flow is not what it was before. that some patients may need a referral to a urologist if they have significant ED. Make sure the patient is aware to look for changes in color or warmth of their extremities because they are at risk for poor perfusion after surgery. And you can teach the patient and or their caregivers to monitor their peripheral pulses. So a dissection is a tear of the inner layer of the aorta. So if you look at this picture here, oh, I lost my cursor. Where did it go? There it is. So if you look at the blood flow entering this vessel, you can see here there's a tear in the lining, and this outpouching is called a dissection. It's a tear through the layer of the vessel. So what happens is, instead of the whole blood vessel outpouching as with an aneurysm, the small area where the tear is gets outpouched in a dissection. If that blood-filled channel ruptures, it is effectively the same thing as a ruptured aneurysm, and it can be fatal pretty quickly. Aortic dissections are divided into two groups depending on which part of the aorta is affected. Type A is more common and dangerous. It involves a tear in the part of the aorta where it exits the heart, or a tear in the upper ascending aorta, which may extend into the abdomen. Type B involves a tear in the lower descending aorta only, which also can extend into the abdomen. Risk factors for aortic dissection include uncontrolled hypertension. Men more commonly are affected than women. Atherosclerosis, weakened and bulging artery or a pre-existing aortic aneurysm. Aortic valve deficit, also known as a bicuspid aortic valve or narrowing of the aorta at birth. The incidence of aortic dissection peaks in the 60s and to 80s. And again, cocaine increases the risk for aortic dissection because it raises blood pressure, and it also doesn't help your blood vessels at all. And sometimes infrequently, aortic dissections might occur in women during pregnancy. And a more recent occurrence is the effect of high-intensity weightlifting. This and other strenuous resistance training may increase the risk of aortic dissection by increasing blood pressure during the activity. And actually, one of the women that I work with, she has a good friend who ended up having several dissections as a result of high-intensity weightlifting. So this does occur, and for those of you who work in the emergency department or who are, who might be taking care of these patients, don't discount that a young, healthy person might be at risk for aneurysm or aortic dissection because of their activity. There are certain genetic risk factors for aortic dissection, mostly connective tissue disorders like Marfan's or Turner's and Ehlers-Danlos. You can take some time and look these up. You don't have to know these for the test, but just understand that some patients may have a genetic predisposition for aortic dissection. With acute aortic dissection, these patients are usually managed in the ICU. The goals of care for them are heart rate management and blood pressure management. And another goal is often to keep them calm and make sure that you're doing whatever you can to reduce stimuli to these patients, give them pain medicine, give them blood pressure medicine, give them anxiety medicine if they can get it. They're treated in the ICU kind of supportively, and hopefully the goal for them will be surgical fixation of those dissections at some point. Preoperatively, we talked about this, make sure your environment is quiet, maintain the patient in bed in a semi-Fowler's position, keep the heart rate and systolic blood pressure at the lowest possible level that maintains vital organ perfusion. So a heart rate, usually you want them below 60, and a systolic blood pressure less than 100. Give them pain medicines and sedatives. You're going to prevent extension of the dissection by managing pain and anxiety, because they can cause sometimes severe elevations in the heart rate and systolic blood pressure. And these patients are nervous to begin with. They know that there's something wrong with their blood vessels, and it's going to be hard to keep them relaxed and calm without some pharmacological help. For patients who have acute and chronic type B dissections with complications, they can be treated with thoracic endovascular aortic repair, which is the placement through the blood vessels. It's an endovascular repair. These doctors go through the groins and place a graft in that thoracic aorta to kind of bypass the dissection. The procedure is similar to endovascular aneurysm repair that was discussed in abdominal aneurysms. For some of these patients may be at risk for spinal cord ischemia because of swelling, and for these patients they can have a temporary lumbar drain inserted. These patients will be cared for again in the ICU after their surgery. Open surgery for aortic dissection is only done in an acute type A aortic dissection, because that patient is going to die if surgery is not attempted. Typically, these patients, they want to control their blood pressure, control their heart rate, and only do an open repair when they really can't avoid it anymore. So for patients who need surgery, it involves taking out the segment of the aorta with the tear and replacing it with a synthetic graft. It is a very high mortality and high morbidity surgery. If you can just imagine the aorta, it's a high pressure, a large artery coming right off the heart. It's a very tough case to do. And you know, many patients who get surgery and who survive the surgery, they can die from complications, including rupture of the aorta, ischemia to the belly, sepsis, heart attack, stroke, and multi-organ failure. These are really difficult things to treat, and when they rupture, it's a surgical emergency. All right, so takeaways from this article, from this lecture, just remember these are all critical care patients. Aneurysms and dissections usually are asymptomatic until rupture, and when they rupture, it's a surgical emergency. So, look at the postoperative care of the AAA patient that gets an open abdominal repair. Look at your signs and symptoms of each one of these ruptures and look at the best treatment for each of them. All right, I wish you well. Thank you.